I'd like to invite Dr. Ajay Katragadda Garu, graduated from Andhra University.
Good morning, everybody. I'm only a pain physician. I'm no longer an emergency physician. But 2 decades ago, we laid the foundation for one of the first few emergency medical services in India. Interestingly, my previous speaker, Dr. Ramkrishnan, took over from me and built up a beautiful department since then, which arguably one of the first MD programs in emergency medicine. I must really congratulate him for continuing the good work. I think it's worth giving him an applause for all the foundation he laid. And I'm indeed very proud to say that I laid the first bricks of that foundation. And I'm so privileged to stand there and say that. So my brick now is to see what I could teach. So how does all these bad things happen? What happens if you leave the pain untreated? There are several microscopic and biochemical events that happen with pain that are unseen to the external eye if you leave pain untreated. That's what exactly that happens. And including drug-seeking behavior, they say, has its onset from the sufferings of acute pain. So let's see, how do you identify pain? Very basic, nothing much. You have seen that young girl who has come with rib fractures on one side. The pain faces the index, obviously, the posture, the body language, the vital signs. And just ask, how many of us ask pain as the pain, how many patients how many doctors ask in the ED, how much pain do you have or what is the pain? Because now it is almost mandatory in many nations that ED or pain is the 5th vital sign. And how do you quantify it? Just the old-fashioned way, just ask how it is, make your own quantification. There are several techniques, just the old numerical rating scale, the VAs, then the functional activity scale, which is more reliable, and in kids, there are the pictorial scales. There are several of them, the most popular one being the Wong-Baker one. So who needs pain management in the ED? Almost everybody. Anybody who has pain. And pain is when people have pain, say they have pain. Yeah, we just, there is, then besides that there are several subsets of people who come with pain, the headaches. And you need to, while managing the cause of headache, you need to manage the pain, and that is some evidence we have. And these increasing, my friend Dr. Arun Kumar sees about 20% of his patient ED presentations are just chronic pains, whether it is bone crisis, vascular events of sickle cell disease or chronic pancreatitis, whatever they may be, they come with pain and chronic pain. US is right now sitting on an epidemic of opioid prescription drug abuse, and the challenges are quite different. So what do we do really? How do we manage these? In a under-resourced country where unorganized pain settings in emergency departments in many of our EDs, what do we do? Knowing and find out what you need, matching the individual need to the local source. If you are stocked with, follow the World Health Organization step ladder systems. So start with simple medication like paracetamol, acetaminophen. Just build it up. Start with the non-steroidal anti-inflammatory drugs, weak opioids, strong opioids. There are times when you estimate the expected quantum of pain for that particular disease, because malingering is possible, because people are always drug seeking, and titrate it to response. And you just follow the simple logics of pharmacology. Just you need to know that some of the patients are critically ill in ED, and you need to know the altered kinetics and dynamics of each drug in critical care. And I find that intravenous route is the most reliable readily titratable form of pain relief, and which is very appropriate. Almost majority of the patients have an intravenous access in ED, and that's the best way to do it. Tailor the analgesic and route to the individual patient. I think there was already a mention by the chair that the time from presentation to the first pain relief is a quality indicator, and is a very good quality indicator. And most EDs they do very well on the other quality metrics, and they fail on this metric. And at the same time, when you use, as you go on to the strong opioids, watch for side effects. It may be simple pruritus to sedation, myocardial and respiratory depression, which is very, very important, especially in the critically ill emergency presentations. But what do we have? As I said, the simple ones keep on building up. One of the things I want to stress, which is underutilized, is the regional nerve block techniques, and which of course requires techniques. It has its own limitations, but there also it's possible and it's very, very effective. Two scenarios it particularly advantageous and this could be life saving is the multiple rib fractures in the elderly and kid. Simple paravertebral blocks. People used to do just the intercostal blocks, and the intercostal blocks do not last long because of the uptake by the vascularity in the ribs. Then one of the commonest procedure is to do the femoral nerve block for the fracture neck of femur, which is very, very handy, especially you don't want to sedate a elderly individual. So what are the consequences? What are the implications of this is that pain relief is important. It has to be logical. Follow the simple, match what you have with what is needed. And look at what are the consequences of it. Look for the side effects, lower your limitations and do it. I know one of the things for procedural things which is underutilized is the buyer's block. Some very cutting edge emergency departments do have buyer's block machines there. But I think most of them don't have it. But there is very handy. You just do the procedure, within 20 minutes this whole thing is done and we send them home. In essence, just do what you have. Work with what you have and do it. There's no point in fighting over what you don't have. The most important thing is be sensitive, be empathetic to the pain of the patient. Just do what you expect others to do for you if they have pain. That's the take-home message I would leave you. And I'm sorry for the slide presentation technical snag, but that's all that I have to mention here.